Kristen Patton from University of Washington, and I'm chair of the Clinical Cardiology, Electrophysiology, and Arrhythmias Committee. I'm here today with Chen from University of Minnesota and Mina Chung from the Cleveland Clinic. And I'm really excited to ask them some questions about their upcoming scientific statement, Atrial Fibrillation, Moving Beyond Atrial Fibrillation Burden as a Binary Entity. I think the first thing that I'm curious about, Lynn, is given the changes in temporal patterns in atrial fibrillation in patients who have a lot of atrial fibrillation for a short period of time and other patients who will have longer episodes of atrial fibrillation for a shorter period of time, how do you define atrial fibrillation burden?
So at the simplest level, atrial fibrillation burden refers to the amount of AFib that an individual has. So naturally, one can look at this as frequency, number of episodes, or duration, the length of each episode. I think many of us would agree that the best way to capture the information on atrial fibrillation burden is a combination of both frequency and duration. So perhaps the best definition is the proportion of time or monitored time that an individual is in AFib, and that can be expressed as a percentage.
And Mina, I'm wondering, the big question in all of our minds is, how does atrial fibrillation burden correlate with the risk of stroke? Do we have some good understanding of that now?
Yes, I think we have some good information. It does seem to correlate with stroke in that people who have non-paroxysmal or persistent atrial fibrillation may have a higher risk of stroke than with paroxysmal. Although our decisions in terms of whether or not to anticoagulate are still based on overall risk scores like CHADS-2-VASc.
And Lynn, I'm curious, how does atrial fibrillation burden correlate with other outcomes besides stroke? Do we have information on that?
So other outcomes include mortality and also cognitive impairment. So we know from some recent studies, particularly those involving the direct oral anticoagulants, that non-paroxysmal AFib is associated with higher risk of mortality than paroxysmal AFib. And we have some evidence from a small pilot study from the ERIC cohort that non-paroxysmal forms of AFib is associated with lower cognitive scores than paroxysmal AFib. But these data still need to be validated in larger studies.
And Mina, do we have any sense of whether some of the lifestyle prevention measures that we're taking to prevent atrial fibrillation will also reduce atrial fibrillation burden?
Yes, actually there are several studies from a couple of them from Australia that showed that things like weight loss and improving physical fitness, a diet with weight loss, can actually improve AF burden and in general in patients who have AFib, but also after ablation. And there is also RACE 3, which looked at lifestyle changes and kind of an upstream therapy approach, which decreased AF as well.
Great, that's heartening. I think one area that's really confusing to a lot of people recently is the subclinical atrial fibrillation that we're screening for, and also how that may or may not relate to a very similar entity, which is device-detected AF. Does the statement help us think through those issues, and what are the differences and similarities between them at all?
So subclinical atrial fibrillation is an area that's receiving a lot of attention right now, particularly with many patients being implanted with cardiac electronic devices. So we find patients who don't have any symptoms with short runs of atrial tachycardia or atrial fibrillation. They can be 2 or 3 minutes in duration only, and it creates this dilemma. What do we do with these patients? Do we need to anticoagulate? This is an evolving field. There is no consensus yet. There are some who believe that they are different from patients with clinical AFib, in other words, patients with manifest AFib whom we are already treating. However, there are some who believe that they are just as at high risk as those with clinical AFib. So this is an area that definitely would warrant more research in the future.
Right, it's a very confusing area because there's a study that shows that as little as 5 minutes of AF may be associated with a higher risk of stroke. Yet, what we are lacking are studies showing that treating that small burden reduces risk of stroke. So hopefully we'll get more information on it. And it's also confounded by the fact that when you look at the device AF burden, the occurrence of AF episodes itself doesn't necessarily temporally relate to the occurrence of stroke. And it may be that there's an underlying atrial myopathy or some other endothelial dysfunction that predisposes to AF and stroke. So I think there's a lot more research that needs to be done in this area.
Thank you. Certainly a lot to learn. Linyi and Mina, are there any take-home messages or conclusions you want to share with the audience?
There are several, and one would be technology. With technological advances in how we can detect AFib and also monitor AFib burden, whether these are wearable devices that you can wear on your wrist or on your chest, this field is going to be rapidly evolving. Even our definition of AFib burden may need to change with time.
I agree with that. We need a lot more research in the area of preventing progression of AF. And we've been focusing a lot on prevention of AF occurring, but there's now so much data suggesting that worse AF burden are associated with worsened outcomes, as we showed in the document, that we really do need to focus on reducing progression of AF.
Well, thank you so much, both of you, for spending time with me. I'm really excited to read the scientific statement. For all of you who likewise want to see what the recommendations are, go to heart.org. Thank you.